Welcome to the Trauma Informed Lens podcast. Each week, Matt, Curt, Jerry, and the occasional special guest explore how the trauma-informed paradigm challenges traditional beliefs and approaches concerning a wide variety of areas. This podcast addresses psychological trauma in an educational manner and is not designed to replace mental health treatment. If anything in this podcast makes you feel uncomfortable or anxious, please talk to a mental health professional.
Welcome back to the Trauma Informed Lens podcast. I'm back here with Jerry and Curt, and in our evolution of this podcast, we're excited to have our first guest, and I'm really excited about having Holly Hanson with us today. Holly and I have been working together in one form or another for about 8 years. Holly does some amazing work in Iowa in the realm of HIV and really public health in a lot of ways, shape, or forms, and is one of those people that I have met in my training and travels and work in the trauma-informed movement, who has had just a huge impact on her state and the people that are in her programs. And I know Holly will say she has also done this by creating a great team around her as well. And I can really back that up as well. But Holly has done some really amazing work. Some of the most powerful work I've seen with the adverse childhood experience study and really how it relates to public health. And so we're going to take a deeper dive into that, get to know Holly a little bit. And like I said, it's such an honor to have, I know, a big special guest for me to start this evolution of the Trauma Informed Lens podcast. So we're really excited to have her on board to talk about trauma health. And the other thing that we're sort of recognizing today is World AIDS Day. This podcast will come out on Tuesday. Wednesday will be World AIDS Day. And I think, you know, I started to do work, and I'm going to kind of transition us into our bright, shiny objects here, because this is mine for this week. I'm also kind of celebrating about 10 years working with HIV providers and specifically in Denver. I've done trainings all the way from Seattle, Washington to San Juan, Puerto Rico, and a lot of places in between with HIV providers. And one of the things I've just come to appreciate is HIV has been such a devastating disease. I like to call it, in some ways, it's kind of an evil virus. It almost looks like it takes a look at a community or a group of people and says, where's the racism here? Where's the poverty here? Where's the addiction here? And it, in some ways, really works its way into these cracks in our communities and takes hold. And I think being around for 10 years, and I've been lucky enough to be working in HIV where we've had really great drugs to treat the disease, taking it from a terminal disease to a chronic disease. But there's still so many challenges there. And I think when I look at the history of HIV services, early adapters, and in many ways, the harm reduction movement came out, or at least really grew and came out of the HIV movement. I know HIV providers were early adapters of trauma-informed care, motivational interviewing, and a lot of others. And so I get the great honor. Wednesday, I'm speaking at the World AIDS Day conference in Pittsburgh. And then the following week, I'm doing a webinar for Holly's folks, actually, talking about building effective relationships with individuals struggling with substance use. And then I get a fly to San Diego and talk to HIV providers in San Diego, California. So big thing on my mind around World AIDS Day. And again, it's great to have Holly on board for that as well. So Holly, we'll throw you on the spot here. I'll do a little bit more formal introduction of you when we transition into our subject. But I just kind of want to, as I know someone who's been thinking about trauma for as long, if not maybe even a longer than I have, I just kind of wondered, when we do our bright, shiny objects, we kind of talk about something that's on our mind in the realm of trauma. And I just kind of want to to throw it out to you. What are you kind of thinking about nowadays as it relates to trauma and the work that you do?
Well, I think a lot about trauma in the work that I do, but I think, and I'll kind of, for the bright, shiny object, bring it in a little bit. And I know we haven't talked a lot about HIV and the care continuum and whatnot, but suffice it to say, trauma is a big barrier for people getting into and staying in care. And one of the coolest tools that I've seen to help our case managers who help people living with HIV to stay in care is a crosswalk that the folks from Oregon HIV program developed. And it's really cool. I just had it up here a second ago. It's a crosswalk that has a behavior that is common for clients, a trauma-informed explanation of that behavior, and then strategies or language to reduce the trauma associated with that behavior for clients. So an example might be if a client is kind of jumping to the worst case scenario or the worst case conclusion. So a trauma-informed explanation of that behavior might be, anxiety, feelings of fragility and or vulnerability, fear of the trauma recurrence, and just hopelessness in general. And so then there's some strategies for a case manager. The strategy cited here is to predict it. And then think about it. Many folks I work with often jump to the worst case scenario because it has helped keep them safe and able to survive and plan in the past. It's how their brains are wired. And Matt, I know you talk a lot about this in the trainings and podcasts that you do. Sometimes we have to force our brains to think of other options, so let's do that together. I hope that we can prepare for good things as well as the worst case. So kind of, and then it goes through several other scenarios like that. And this is a tool that we are getting ready to roll out to our case managers to help them in a very concrete way as they go through their work days.
Very cool. And is that, is that available online that we could get a link to our listeners?
Yeah, that's how I got it.
Awesome. Well, we'll put that link in the show notes. So check that out, because I think that scripted thing, especially for people new to this, can give them some comfort level, because I think a lot of times, and I'm careful of this, I know we all are as trainers and advocates for this, it can be overwhelming with all the neurobiology and all this other stuff. So some scripted stuff, especially for people that are kind of new to the concepts, is actually a really cool idea. So I'm excited to check that out as well. Very cool.
Absolutely.
Curt, what are you thinking about this week, my friend?
Well, you know what, Holly, what you were mentioning about some strategies and something that you can almost use as a shortcut or a way to memorize and create some habits about how to respond to people, I think is really a very trauma-informed kind of approach, actually. If we think about habits and how habits get formed in terms of a trauma-related perspective, where extreme circumstances generate symptoms, and then those symptoms become ways to deal with situations that are the same or similar throughout the course of the lifespan. The same thing can hold true if we learn good habits and learn good ways to do things and positive ways to deal with situations. We can develop those habits in the same way. Jerry knows one of my favorite interventions is what I would call the back pocket phrase, where you have something that you have memorized for what you can say when you get stressed out. When somebody says something that makes you feel threatened, you have it memorized so that you don't have to think about it and you can just say it. And so I like that. I like that a lot. I think that the more I get to talk to a diverse group of people, the more I find that there are so many great little ideas and so much convergent validity in some of the ideas that we generated as a way of dealing with what we do in our jobs. And then from a very diverse background here, you share something that matched up with something that I've thought for a lot of years. So I really enjoy that part, and I'm super glad to have you on the show. I think it's really great. I'm excited to hear what your study is about, and I think it's just wonderful.
Very cool. Jerry, what about you, my friend? What are you thinking about this week?
Well, you know what I'm thinking about is the power of relationships. And, you know, I've had the luxury of working with nurse family partners this week, and how powerful it is to have somebody present who can listen to your story, and not necessarily immediately want to take away your feelings or change your feelings, but just really be able to listen. And then when you listen, then figuring out really from the person's perspective, what that feels like to have that experience. Yeah. And I think once your client understand that you understand, then they're really open to some of the suggestions you have about distraction or other kinds of things. But I think when we go in too quickly to try to distract them or take away something, it feels invalidating for them. And so really I've been just so impressed with these group of nurses who sit with really painful, both psychological issues with young mothers and with medical issues with young mothers, and their capacity just to listen and the power of that really to make changes in people's lives. So, you know, the relationships in themselves are incredible medicines. So I think that that's the takeaway from me this week is to, in some ways, to maybe write something on my hand about wait before talking. So, right? It's just sit and listen and then talk.
That'd probably be good for all of us on this podcast, especially since we have a guest on this week. But I had a great opportunity at one of your trainings, Jerry, that you invited me to sit with that group, and just some of the wonderful people. And I tell you what, I've learned, especially in my work in healthcare, if nurses like you, you're doing something right. So, and boy, do they love Jerry. There's a mutual respect and love there that's really cool. So it was good to meet some of those folks. I know you've done some really great work over the years with them. So a great group. So I want to transition into Holly's study now, and I'll just give a little bit of background with my experience of this, and then Holly will give you all the great information here, and we'll talk about it. But I saw this, and as somebody who talks about the adverse childhood experience study, which we covered in an earlier episode, and there's a lot of great resources online with, and somebody who's done a lot of work in HIV, I could have told you and probably bet a lot of money on the fact that those living with HIV would have a higher rate of adverse childhood experiences. I mean, that would be something I think, you know, Jerry and Curt would also agree upon, that we would expect that. And yet, when this study came out, I think seeing something, and this is where I give Holly and her crew a lot of credit, seeing something very concrete, like the study that she did, it kind of hit me. It kind of made me step back and think, what's going on here? And again, I would have probably expected some of these outcomes, but to see them come out in Iowa in the way that it did was really impacted me in a way. So I'm excited to turn it over to Holly and let her share so what her insights in the study that she did. And for those watching the video, I'm going to put some of these slides up on the screen here. Holly's going to talk through it for those just listening to the audio. They've created a great report that I will put in the show notes as well. So I'm going to flip it over to these graphs here, but we'll try to bring those to life for those just listening as well. So Holly, I'll hand it over to you, my friend.
All righty. Well, first of all, Matt, I want to thank you for such an amazing introduction, and I'm very humbled by it. You have been so instrumental in the training of my team and then all of our subrecipients, and you know, we continue to increase our training with them. I've purchased everybody books, and the motivational interviewing practicalities have been wonderful for everybody. So I am so appreciative of the work that we've done and look forward to the work moving forward.
Mutual, my friend.
Well, thank you. And then before we go into the study, I want to echo a little bit of what you said, but also for those that are listening that aren't familiar with HIV and the state of this, kind of the state of the disease right now, just kind of a quick little overview of what we call the HIV care continuum. And what that is when you start on the left-hand side of like a bar graph, the left side is how many people are living with HIV. The next bar is how many of those are diagnosed, and those bars go down. So in Iowa, it's around 3,000 people are living with HIV, but only about 2,600 have been diagnosed. So one of the things that we want to do is find those people living with HIV so that we can get them in care and get them the treatment that they need. Now, we know that just because you're diagnosed doesn't mean that you are linked to care. In Iowa, we have a very high rate of getting folks into care. That's at around 98%. Once people are linked in care, many don't stay in care. So at any time, there's probably about 25% of people living with HIV that aren't in care. So one of the biggest things that we are trying to do is not only get people in care, but keep them in care. Because ultimately what that does is that they are adherent to their medications then, and their viral load then is suppressed. And if the viral load, the HIV virus is suppressed, it means that they are going to get the best health outcomes available to them, which basically now means living a life expectancy the same as somebody who does not have HIV.
Yeah.
But the other thing that that means is that they're not going to transmit the virus. So it becomes both a prevention and care endeavor for what we do in our work. So what are the biggest things that keep people out of care? Well, there's a lot of things in Iowa like transportation and that kind of thing, but ultimately the biggest barriers are substance abuse and mental health issues. And it became apparent to me a long time ago that a lot of that has to do with adverse childhood experiences or adult trauma. So I've been looking for ways since I've been working in HIV for over 16 years to bring that to the forefront. So meeting you, Matt, what we said 8-9 years ago was a big part of how we managed to get that done. So like you said, I always expected a high ACE score for people living with HIV, but to make the case for increased resources towards a trauma-informed care, I wanted to find out for sure and be able to show this, even though those of us in the know are like, oh yeah, of course.
Yeah.
And just like you, when I first saw these numbers coming in, we were able to see the results live as they were coming in. It was so clear, the difference in the ACEs scores between the general Iowa population and people living with HIV. And honestly, I got tears in my eyes when they started rolling in.
Yeah.
So that's my big premise before talking a little bit more, getting into the weeds of the study. So I can do that now. So what we did is 8 categories of the adverse childhood experiences, or ACEs, which of course measure childhood trauma, were collected on our consumer needs assessment, our HIV consumer needs assessment that we do once every 3 years. So they were collected, they were calculated and determined by the total categories of ACEs reported, with the scores ranging from 0 to 8 in this case. This was so that we can compare it to Iowa's overall population, for which experiences of ACEs were collected through the 2012 to 2014 Behavioral Risk Factor Surveillance System, lovingly known as the BRFIS, of over 19,000 Iowans. And as you can see here, results indicate that experiences of childhood trauma of respondents to the HIV consumer needs assessment were significantly higher than the general population. So overall, the consumer needs assessment respondents were more likely to identify more adverse childhood experiences than BRFIS respondents. So as you can see from the table here, 1 in 5 respondents, or 20%, reported 0 ACEs, compared to 44% respondents to the BRFIS. 21% of respondents to the consumer needs assessment reported 4 to 5 ACEs, compared to 9% of the BRFIS respondents, while 5% of BRFIS respondents identified 6 to 8 ACEs. 16% of Iowans living with HIV identified the highest number of ACEs there. So really significant differences.
Yeah. So I'd like to just pause. I know we have another really good slide that I want to get to as well. But, you know, when I started to look at this, and Jerry and Curt, I'd love to get your first impressions on this as well, especially the further down you get in the chart here, the 4 to 5, the 6 to 8. I'm still kind of just, again, not surprised, but just hit that those that then end up in, you know, getting most, and Holly, correct me if I'm wrong here, but looking at the report, most folks got diagnosed with HIV and probably contracted the disease in adulthood. So these things happen to them as children, and then they participated, and again, looking at the data, usually in a sexual behavior or a drug use behavior, especially with ejection drug use, that got them, unfortunately, the diagnosis. And so then we see 3 times, 2 times as high as rates. So, you know, it just is a powerful reminder of that piece of childhood experience. And Curt and Jerry, I just kind of wonder, you know, as you guys looking at this kind of for the first time, just kind of any thoughts as we see some of what we talk about get broken down into percentages when we look at complex trauma.
One of the things that strikes me about this graph is that the shift between when the 2016 survey respondents started to have more exposure to ACEs happens at 2 to 3.
Yeah.
And that's an interesting point at which that shift would take place. So I had the thought that, is there, and I'm not even aware of any of this literature, is there some kind of literature that tells us that if you're a person who happens to be in the category of a socioeconomic status or a class or an environment where 0 to 1 is a common response to this survey, is it somehow fundamentally different to be a part of a culture or a class or some group where 2 to 3 becomes more the norm than 0 to 1? That's an interesting division that it wouldn't just be across the board that you would have that shift. You know, it makes sense that you'd have 0 be a difference, lower reporting on the 2016 survey. But why 1? Why isn't 1 shifted as well?
Yeah.
I think that's kind of an interesting part of that data.
And what Curt's talking about, for those that don't see the graph, is people with 1 adverse childhood experiences, those living with HIV, 17% of them had only 1, and I say only 1 just from a statistical, not an experiential point of view, whereas the general population had 22. So actually, the general population ranked higher on the 1 ACE than those living with HIV, which I also found that fascinating. And then when you kind of think about the impact of complex trauma, it might make some more sense, but at the same time, I think that's one of the things that jumped out as me as well. Jerry, any thoughts? Oh, go ahead.
Well, I was just going to say, I think most of the people are, you know, having, you know, over 2 ACEs. And so those are just lower numbers in the 0 to 1. There's just not as many of our folks that have the lower ACE score.
Yeah.
Even adding those numbers up, that 1 category is lower than 0. So there just weren't a lot of people that kind of fell into the 1 category even. I mean, I don't know how useful it is, but it sure is interesting to me.
Yeah. Yep. Jerry?
Well, I think there's several adverse childhood experiences that if you have 1, it's so much more likely that you'll have
Good point.
the 2 to 3 to 4. Yeah.
Really good point.
So you know, both the magnitude of the statistical difference between these groups is really impactful. But when you look at it, there's still a significant number of people who are reporting ACEs who are not living with HIV.
Yeah.
And so what is the protective factor in their lives that is in some ways present, that allowed them in some ways to cope with the experiences that they've had? Because I think it's really important to kind of take away from this large population is that when you're exposed, it increases your risk. But there's also a large percentage of people in this population who are exposed who also have resilience.
Yeah.
So we want to kind of learn from that particular part of this process as well, so that really as people go along through life, not only is the early childhood exposure put them at risk, but their lack of relational connectedness and access to resources along the way probably increase their chances of future risk. So I think that this is a really great study to kind of look at and begin to raise the question in our communities is how do we intervene earlier into this process rather than in some ways waiting to treat the outcome of really these exposures, but really reducing the risk of exposures in the beginning to kind of look at those things.
Well, and one of the things that we don't know about that the general population here too is while we're separating this out with those that are living with HIV, you know, how many of those in the general population might be struggling with addiction or homelessness or other potential symptoms of trauma? I mean, like I said, HIV is interesting when you look at it is, you know, while some folks may have engaged in maybe riskier sexual behaviors or their drug of choice involved injections, you know, we don't, again, there's questions about the larger population, but again, it really, like you said, Jerry, the takeaway I think is that if we can get treatment early, whether it's alcoholism or public health issues like HIV or diabetes or cancer or whatever it is, that early intervention is so critical. So these aren't the long-term consequences of people not getting trauma treatment.
Right. And the statistics would support what you said, right?
Yeah.
The increased level of substance abuse, the increased level of obesity, the increased level of mental health issues. So really, when you look at this population, the correlation between increased adverse experiences and that, but really as a society, we end up treating the outcome of that.
Yeah.
Really to get to the spot in our communities, in our allocation of resources is how do we create a more healthy, more health facilitating communities that in some ways, even though people are going to get exposed, it will reduce their risk in the long term.
Yeah. Holly, what are your thoughts about what Jerry's saying? I know we all agree, but I just kind of want to, as somebody that's on the ground in the public health arena, looking at a statewide population, I just kind of
what happened here?
What's your thoughts on that?
So I have a couple thoughts about some stuff that Jerry said, you know, with the power of relationships. He was talking specifically about the healthcare setting. It really rings true with something that's going on in my personal life right now. And I've been comparing that a lot with the care that we provide for people living with HIV in Iowa. Recently, and you don't have this slide, Matt, or the information, but one thing that we've been doing in our quality management group in the Ryan White program is we pulled out the people living with HIV in Iowa, those who receive Ryan White Part B services and those who don't, and we looked at their viral suppression rate. And it is staggering, the difference. And I think that goes to what, Jerry, your point was earlier, because the services that we provide are very comprehensive and thorough. And so in our philosophy now is you don't graduate from case management. You just go on a lower tier, and we still want to stay in contact with you. So you can have as intense or less intense level of case management as it fits your life at that time. Now, this is juxtaposed to my brother has been in ICU for the last 2.5 weeks, and he does not have HIV. And the services, I mean, there's been wonderful nurses, and that relationship is there, but the services don't compare to what a person with HIV has access to in Iowa. And so it kind of gets to what you were talking about earlier with that general Iowa birth population. And we're looking at this sample size of 19,000 people. And Matt, you're exactly right. It's like, so most of them do not have HIV. I mean, we only have 3,000 people in Iowa living with HIV, but they struggle with all these other issues potentially with mental health and substance abuse. And, the stigma surrounding those issues is so significant that if you're at Mercy Medical Center or Methodist with, other physical complaints, those are addressed, but it's very difficult to get behavioral health involved. You really have to reach out for it and try and bring it into you. It's not offered like physical therapy or occupational therapy. You have to ask specifically for behavioral health, it seems oftentimes.
Yeah, and I think that's, and so I didn't know that about your family, so obviously all of our hearts go out to you and hope the best.
Well, he's going to be okay.
Good.
He's out of ICU now, but yeah, he's
good.
Doing well.
But your experience is so, I believe, telling, and I've heard people, and I want to be very careful with this, that I respect these words, but a lot of folks, because I always, when I go to conferences or run across people, I've done a lot of work in the with people living with HIV, community work, outreach, needs assessments. And so I always like to ask the question, how are you doing so well today, especially if they share their story of their struggles? And I've heard over and over again, people say, HIV saved my life. And it's not like getting this terrible disease, which it still is, because even if you're on the medication, there's side effects. There's a lot of complications going on with that still. But they got in and they found a case manager. And these case managers are usually that frontline person. In bigger cities, it can be an outreach worker at times. But they built, like Jerry said, that relationship with somebody. And then in kind of an ironic way, because they got into a system like Holly's system, they got access to housing, to substance abuse, to mental health, and in a system where a lot of times, I know rural providers, there's a lot of challenges, but a lot of times we're trying to convince people to go into mental health services or substance abuse services, whereas sometimes in the general population, there's a lack of access to those services. So it's that really, I wish, and Holly, I think your words are real powerful with this, that in some ways everybody who is struggling with these got the same level of wraparound services that I know your folks in Iowa get, and that life-changing experience for folks as well. So I want to move up here because I think this deepens our conversation. And Holly, do you want to go over this draft? I went the wrong way, but with the individual ACEs and the outcomes here, I think this is incredibly powerful as well.
Yeah. That first figure is so powerful, but this one is even more powerful to most people, including myself. So when we look at specific adverse childhood experiences identified, there's striking differences between respondents to the HIV consumer needs assessment and the respondents to the Iowa BRFIS. In all 8 categories, as you can see here, higher proportions of people living with HIV reported they experienced trauma compared to the BRFIS respondents. And you can see most people are listening, aren't they? Okay, so I'm kind of go through some of them. So for emotional abuse, people living with HIV, 49% of our respondents reported having experienced that, compared to 28% the Iowa Burfess. Physical abuse, 43% to 16%. Sexual abuse, 32% to 10%. Adult substance abuse, 40% to 26%. The parent separation divorce, 39% to 22%. Mental illness among adults in the household, 30% versus 17%. Violence between adults, 37% to 16%. And then a member of the household incarcerated, 13% versus 7%. So in almost every single category, it's at least 2 times as high for people living with HIV, with sexual abuse as high as 3 times as high. Some of them are 2.5 as high, 2.5% or 2.5 times as high. So really, really significant when you break it down to the specific categories.
Absolutely. And boy, that sexual abuse just hits me like a ton of bricks, knowing that a lot of folks that end up living with HIV got it through sexual contact. Some of it, I don't always say risky, because some of it's not risky. It just, wrong set of circumstances, so to speak. But, when you look at the physical abuse and the sexual abuse and the emotional abuse, we've got already, when somebody gets that HIV diagnosis, which also can be a trauma in somebody's life, it's another trauma on top of all of this pain and suffering. And it just gives me a whole lot of, respect for your case managers and nurses and other great professionals in your system that have this, sit across from them hour after hour, day after day, and do some amazing work as your outcomes.
So Holly, as I look at this, I'm thinking about how powerful it would be for an individual who people are dealing with their behavior and their medical condition to really, in some ways, understand the relationship between their life experience and what they're dealing with. And I wonder what you or your staff's experience sharing this with your clients, and how when they make a connection between, oh my God, it's not that I'm this bad person who engaged in this behavior, I'm an injured, hurt person who was trying to cope with some really overwhelming experiences, and how that changes both for your clients, but also it changes the relationship between your case manager and that client.
I hope that there's those kinds of things going on out in the field. I can tell you that, we require everybody to go through trauma-informed excellence, which was developed by Matt. I think we were his pilot state, right?
Yep. Yes, you were.
And so a lot of that has to do with learning about trauma, ACEs, and how it will affect their clients and stuff like that, but also a lot of self-care, which, working with people with high levels of trauma, you really need to be careful to not get burnt out. There is, I think, room for some more concrete. We have to be careful because our case managers aren't therapists. And so a lot of what we kind of train them to do is refer out and kind of develop these relationships with people that are with therapists that are trauma informed. And in our larger agencies, we have integrated behavioral health consultants into the clinic flow, so that we can have some more direct impact on mental health and behavioral health. And part of that is convening this idea about this. And I think that it is a huge relief for people to have this perspective. But I do want to increase the work on kind of monitoring that and seeing what the direct impacts are. This survey was done in 2016, so we'll have another survey going out in 2019, and I'm want to try and figure out a way to maybe track this over time, see if we can get some improvements over time, but then kind of somehow integrate some sort of way of monitoring how a trauma-informed approach helps them stay in care longer.
Right, right.
I mean, I love studies like this, and I was thinking that, I mean, the data just speaks for itself. I mean, and the way that you presented it it tells a great story right there, and so it reminded me of a comment that I heard from the president of a organization that I worked for, who was known to be very, I mean, he was an attorney and a business guy and a finance guy. And so when he started talking about being trauma informed and why the organization as a whole should become trauma informed, he presented it from a statistical perspective. And it made me laugh. I just loved it, right? And he said, there's no risk if we make a type 1 error with trauma informed care. That if we go false positive, we don't hurt anybody that way. Yeah. As opposed to if we make a type 2 error and we don't identify it, we can hurt people. And so I thought that, I've remembered that ever since, and thought that was a great way to say it. And looking at your data, I'm just like, no risk of a type 1 error here.
Yeah.
So, right. Assume that this has occurred and treat people from a trauma responsive lens, and you won't go wrong. And one of the things that I really love about a trauma-informed approach is that it goes, for me, it goes beyond just trauma. Understanding how the stress response works, understanding how the brain responds to the stress response is really like human informed more than just trauma informed. And so I love that approach, and looking at that data, that comment just popped into my head of like, yeah, you got no risk of a type 1 error here.
Yeah.
Being informed is not going to hurt anybody.
Great. You know, the other thing that I think, and I kind of like everybody to, not just the four of us, but all the listeners as well, is the other thing that I've really thought has been powerful in HIV work. And Holly mentioned what's called the HIV Cascade. And again, what we know is even for folks that know their diagnosis, only a small fraction of those actually, and it's, I think 82% nationally, CDC information still puts 82% know their diagnosis, 25% reach viral suppression. And for those not familiar with HIV, that's sort of the ultimate health outcome that we're looking for. That means that when they do the test that they can't find the virus. It's still there, but they can't, it doesn't show up in the test. And you're basically living, for the most part, a healthy, a normal, healthy life in many ways. And so when you look at that, 82% no, 25% reach that outcome, it really shows. And then you look at that Holly's data, and I think HIV is really getting this in a big way with the services, is trauma becomes the ultimate barrier in many ways. Now, homelessness, addiction, mental health issues might all come to the service when you ask, okay, why isn't this person getting the health outcomes we want them to get? But then we ask, okay, what's behind those? And trauma is the answer in so many situations. Again, not all situations, because 20% have had the 0 ACEs in Iowa, but for the vast majority, barriers to the outcomes that we want. And I think that really transcends HIV in so many ways, of being such a powerful player, whether we're in mental health, substance abuse, or other things as well. And I just kind of want to throw that out. Holly, any thoughts on that? Or to Jerry and Curt of, you know, when we think about it from an outcome perspective, what is the role of trauma, and how does trauma-informed care sort of help us address maybe the underlying issue to a lot of these other things?
Holly,
well, I think, oh, sorry.
Go ahead, Holly.
So one thing is that the viral suppression rate is a little bit higher. I mean, we're really in the last even 2-3 years making great strides in that viral suppression rate. The goals in a lot of places is this 90-90-90. So to have 90% of people living with HIV diagnosed, 90% retention, and then 90% viral suppression rate. And some places are getting really close to that. If you're diagnosed, that is being achieved. And a lot of it does have to do with some work around stigma as it pertains to not only the things that we've been talking about, homelessness, mental health, substance abuse, and ultimately the trauma that causes those things, but also there's some reduced stigma in just people living with HIV knowing that if they are suppressed, if their virus is suppressed, they will not transmit the disease.
Yeah.
And so that really has been helpful in keeping people in care. That's the first thing I wanted to say. And then the next thing is, you know, we're kind of talking about just living with HIV doesn't mean you have an ACE score necessarily. Many people living with HIV, as you saw, you know, there's still 20% that have 0 ACEs, and, you know, and they're in care and they're doing their thing and they're doing well. But if you look further down on the study, you know, we also crossed the ACEs scores with some other issues like homelessness, also incarceration, use of tobacco, use of non-prescription drugs in the past 12 months, and whether they had a detectable viral load or not. And serious mental illness. And as you can imagine, the higher the ACE score for all of those, the more likely the thing would be. So for example, incarceration. So 0 ACEs, 20% are incarcerated. If you had 6 to 8, 57%. And for all of those issues. So I think it's important to remember that, you know, that higher ACE score really increases your risk for so many things.
You know, I'm first of all, you know, these numbers are just great in terms of kind of helping us conceptualize and ask different questions about how we can be of help and how we can kind of, right? So this trauma-informed ACEs studies looking at really allow us to kind of, in some ways, begin to ask different questions and develop different interventions. But I also, you know, it makes me think about how, Matt, we've talked a lot about is sometimes when we begin to look at these scores and we begin to look at what the data is telling us, we have to kind of go back and deal with the fact of how did we deal with people before we knew this, right? And what was the impact of coming in and just getting medication, or us just treating your substance abuse, or us just telling you that, you know, you having unprotected sex that is bad, really is, these numbers allow us in some ways to connect in a compassionate way with the populations that we're serving. Yeah. and to provide them not only an intervention into whatever is biologically dysregulated within them, right? But also in terms of just being that support system to be able to kind of help in the connections. So I think this data is really powerful in helping people reframe and understand that we're dealing with a group of individuals who really have survived an incredible amount of adversity, as opposed to that there are these individuals who have these, you know, something that went wrong. It's like, wow, how much has gone right along the way that allowed you to survive through so much of this stuff. Yeah. That is a really different relationship with our clients, and I think it's an important outcome to the work that you're doing to kind of help us all look at these problems in our society from a different perspective and approach them in a different way.
What a great way to think about and expand our thinking about data-driven decision making.
Yeah.
Data-driven decision-making, it just isn't just about error correction or detection and correction and remediation, that it can be about relationships as well. That we could use data to help us connect with people better. I think that's a really cool approach.
Absolutely. Holly, we're kind of running up against time here. Any last words that you would like to share but before we start to wrap up here?
Well, I think that I would be remiss if I did not do huge shout out to person it sounds like most of us know, my former boss who made me into a trauma junkie, Marguerite McCormack. She really, really changed my life when I worked for her down in Columbine Connections in Littleton, Colorado back in 99 to 01. My current boss, Randy Mayer, who is very supportive of my ideas. And then really most importantly, my team here, the Ryan White Part B team, that none of this would be possible if I didn't have them to do what they do every single day.
Yep, and I would back that up 100%. Holly is brilliant, but one of the ways Holly is brilliant is she surrounds herself with brilliant people. I don't know how she keeps finding these folks. I don't think anybody else in Iowa has decent people because Holly finds them and takes them all. But Biz, I've known Joe now as well. Huge fan of Randy's, obviously, and they've got a great leader in you too, Holly. So as we wrap up today, I want to give a big thanks to Holly and for her folks for sharing all this information as well. We'll put all of this in the show notes that you can find at traumainformedlens, all one word, .org. You can also find our fun videos there as well. Just a final word as we go in again, I want to just recognize all the great work being done around the country in HIV, from the amazing physicians, nurse practitioners, nurses, all the medical professionals, the case managers, the therapists, substance abuse counselors. It's something, if you're not in the public health arena, I wasn't much aware of the HIV, which is what's called the Ryan White system. But as we enter the HIV World AIDS Day, I would just encourage you, if you're not in a field that thinks a lot about HIV testing is a huge thing. We're now trying to get 0 new cases of HIV around the country. And that's a huge goal. That's, as my favorite business author, Jim Collins, says, that's a big, hairy, audacious goal for us. And we need everybody to do it. So even if you're not in the field specifically, think about testing, think about reaching out to usually AIDS Project or an AIDS service organization in your area. If we all can do a little bit more testing, we can get on top of the new cases and hopefully in our lifetime get rid of this disease. I think we're getting closer and closer every day. So thank you, Holly, Jerry, and Curt. Always.
Thanks, Holly, for being here with us today.
Thanks so much, Holly.
Oh, it was awesome. Thank you so much.